Okay. Um, so before I go on into the punishment-resistant part of pain, I want to talk a little bit about our punishment learning circuits and how those contribute to pain chronicity. So as we mentioned before, pain activates punishment circuits. Those include cortical punishment circuits like the cingulate, and that drives cognitive responses to punishment, like trying something new, for example, as well as the amygdala, which sort of more deep emotive brain part, which learns fear responses to punishment, including increasing anxiety in potentially threatening situations or situations where you learn that bad things could happen, and avoiding contexts where punishment occurred. So punishment learning tends to drive both fear and avoidance of situations where pain gets worse, and that commonly is patients can develop fear of movement, fear of injury settings, like for example, if somebody had an on-the-job accident, they may have an awful lot of trouble going right back to where they were hurt before. And one piece that we'll come back to in a little more detail is drug withdrawal. So people feel really lousy when they're in drug withdrawal, and so they get really good at avoiding never having their drug dose go down. And they will develop anxiety, substantial anxiety in these settings. The problem with that is anxiety is one of the things that amplifies pain the most. So if you're scared, if you feel threatened, if you are anxious, your pain is going to be way, way worse than if you're not. Sorry, I need to use this one. So there's a whole model that people have developed whole therapies around called the fear avoidance model of chronic pain. And this describes the way that fear learning can maintain and worsen chronic pain syndromes. The idea is if I have an injury, I'm going to get pain from that injury. If I catastrophize, so if I assume that this pain means that I'm in danger, terrible things are going to happen to me, I'm never going to get better, oh my God, my life is over, or I'm going to die. Any of that catastrophizing will lead to and exacerbate fear, so make you more nervous. That's going to make you hypervigilant. You're going to pay attention, look for any little threats, and be really, really good at detecting them. And it's going to make your muscles all tense up, feel bad. That's going to increase the amount of pain you experience. That fear is also going to trigger avoidance, and that in avoiding things too much is what causes dysfunction, right? Disability over time. I'm scared to do any of the things that I used to do or that I want to do. And that can lead to depression, and depression is probably the next best thing for amplifying pain. So if you're feeling sad, down, whatever, that amplifies pain, you get more pain. And so you get stuck in this cycle. So your pain gets worse, something terrible must be happening, and you're back, and eventually you're avoiding life and you're feeling lousy all the time. The way out of that circuit is generally to help people get over their catastrophizing, help them understand that the pain is normal. It's just a warning. There's nothing necessarily terrible that's going to happen to you. The pain that you may be feeling may have to do with your emotional state, what you're thinking, how you've been trained more than the actual injury. You may be perfectly fine. Maybe you are safe, right? So getting people to understand that helps them confront their injury, work on getting better, and can lead to recovery. So there's a whole variety of tailored cognitive behavioral therapy protocols that focus on this model, help with everything from walking people, doing fear exposure, so helping people figure out what are the things that they're terrified of, that are stopping them from doing well behaviors, and hand-holding them through that, working through it safely, to other cognitive behavioral therapy techniques to address this sort of learning. So one thing I point out as well, just like patients, can drive reward learning in clinicians, patients are also punishers, essentially, to providers. So viewing pain causes pain in the viewer. So insofar as a patient in pain comes into your office in pain, they are punishing you to some extent. That's going to, in addition to maybe triggering your desire to help them quickly, is going to trigger avoidance behaviors. Want to make you get away from that patient as quickly as possible. So it's going to encourage behaviors that get that distressed patient out of your door. It's going to discourage discussions that really bring pain to the forefront to get clinician attention. It'd be better if the patient just wasn't paying attention to their pain. We could talk about something else, and then I don't have to bring it all up and feel the pain with them. And that's going to really discourage frequent visits as well. You're not going to want to tell them to come back next week because really you don't want them there. And again, this not conscious. This is fear learning circuits. This is deep brain stuff. But it's going to impact behavior over a population on the whole. And we do see a lot of that in patients who have way less frequent follow-up visits than they should have. Clinicians would rather not talk about pain. And I will say, as a way to try to address this piece, right, that there was a sense that clinicians just weren't talking about pain because they don't want to. And I've talked to a lot of clinicians, and they really don't. A lot of them don't. Some of them, this is their thing, and they love it. Lots of clinicians would really rather not. So in order to try to get people to talk about it, Joint Commission basically made up a fifth vital sign campaign where they said, every time somebody comes into a visit, one of the first things you need to do is ask them how bad their pain is. And it was incredibly well-intentioned, but what it does is it makes pain the focus of every visit. And that sets people up to either, okay, great, now I got to get this patient out of the room because I really don't want to deal with this, or all right, fine, I need to get them better right away. Here's the pain pills, and now I can deal with their diabetes, right? So you get, even though it was well-intentioned and trying to address that, I think it has in fact made things worse, potentially. The other thing I point out is pain, the pain that you experience from your as empathically through your patients is going to trigger fear conditioning and cause anxiety about interactions with pain patients. And I will say clinicians, not universally, but I've seen so many clinicians who are incredibly anxious about dealing with their pain patients. They feel helpless. They don't know what they're going to do. I think this shows up in surveys as I need more pain education. And so what you get is like, oh, great, we're going to do endless continuing ed to teach you more about pain pharmacology and so on and so forth. I don't actually think that's what's necessary, but that's how I think that tends to get interpreted. Okay. So what do these do? What do these tendencies towards do to providers? So what you have, right, essentially when you have a pain patient come into a clinic is you've got a patient-provider dyad, both of which share a drive towards quick relief seeking, right? You both have activated reward learning circuits that are going to be biased towards quick fixes and against recovery-focused interventions. So whether you like it or not, part of your brain is gonna be working against you to try to do the things, to help the patient do the things that you need to get them to do, and not. And so you've got this not so great part in meshed clinic and patient interaction. We know that prescribing opiates and other reinforcing medications is gonna provide quick relief for the provider too. It's going to take care of all sorts of things, right? You want the patient to get better right away. You're going to avoid the patient having to go through withdrawal because that's not fun, and maybe you don't know how to taper them anyway. And it gets them out of the office, or you can talk about something else, right? So what can clinicians do to stop themselves from getting into these sorts of habits that cause everyone problems, that cause pain chronicity and over-reliance on opiate therapy? And how can we really start reshaping how we do clinical practice and how people learn after pain? So the first thing that I would say is I think we need to retrain providers to think of themselves as coaches rather than superheroes. Clinicians oftentimes think of themselves as the person who needs to come in and save the patient. They came to you because they're in trouble. You have to save them, and you have to save them immediately, right? All right, that sort of, come to the rescue, provide immediate relief. really comes from a focus on pain severity. So long as I'm sitting there worried about how serious do they have a 10 pain or do they have a 4 pain, I'm going to be worried about getting them to feel less pain right now. And we talked about reasons why that's really not that helpful. Coaches, on the other hand, really focus on encouraging and enabling people to do the hard things that they need to do in order to get better, have sort of a focus on recovery or function. And this piece right here, if you talk to pain specialists who love working with pain patients and whose pain patients always get better, this is the big thing that differs between what they do and what clinicians that struggle with pain management do, is they focus on recovery and function. They ask about pain as a sort of secondary thing. I just kind of want to know. What I really want to know is, how are you doing towards making it towards your goals, and what are we going to do to get you functioning better? And everything else kind of becomes an afterthought. And when you reshape your practice to focus on this, I think a lot of the rest kind of naturally falls out. So just point being, everyone loves to be the superhero, but really we want you to be the coach, the somebody who tells the patient what they don't want to hear, tells them the things you see that they don't want to see, so that they can become, the person that they really want to be, right? May not sound as fun, may not be as immediately rewarding, but that's what's going to get your patients better. And it is, in fact, incredibly enjoyable once you get really good at it. So we're going to talk, one of the big things that the new guideline focuses on is trying to get people to treatment plan and do evaluation with a focus on function. So how are we going to reinforce recovery behaviors and teach people to get well, right? So how are we going to get this person, right? You need them to do their walking. Obviously, they feel better right now if they take a nap on their treadmill, but how are you going to keep them going, right? And so what can we do to change our clinical care processes to focus on long-term focus and treatment planning? So the first thing, and probably the most important thing for improving the outcomes of your opiate trials, and also is to focus on functional goals. And the nice added bonus of doing this is, if you focus on function, people always worry about, like, how am I going to tell the addicts from the people who are just taking pain meds because it helps them, right? Like, how can I tell the people who are struggling from the people who aren't? Because, and if you focus on function, it becomes really, really obvious who's having the negative consequences and who's having benefit, right? Because you can't tell necessarily with pain severity. Their pain severity may be an 8 and they're doing fine and they're getting a lot better and everything's going good, and it may be 8 and they're doing horrible. But you can't tell what's going on until you find out what else can they do the things they care about. So I note, if you do an opiate trial with a patient, if you have functional goals that you're monitoring, you can tell if they're showing improvement in function or getting worse. And the people who are showing improvement in function, that's a positive trial. It's okay, keep them on the opiates, seems to be helping until it's, at least until it's not helping anymore. But if you have a patient that's showing declining function over time as you give them more opiates or as you increase their dose, that's going nowhere good, right? They may have abuse or addiction, and you may want to get them screened by an addiction specialist. They may have disease progression, and you always have to rule that out, make sure that they're not getting worse because they're getting sicker. But assuming that, but if that's not the case, don't keep the opiates going. It's not working. There's your solution. It doesn't matter whether they're addicted or not. You've got to get them off because it's not helping. And so the things you need to pay attention to in function, you want to monitor mood, you want to monitor social or physical function, activity level, sleep, as well as pain severity, with a stronger focus, I would argue, on those. And you really want to, and I know this is hard to do in a visit, but you want to find out what the patient actually cares about, what would make them better, and monitor specifically for progress towards that goal and help them with that. And I know a lot of medical clinics are not set up to do this sort of planning, but this is why restructuring some of how we we interact with pain patients, I think matters. And so here, just to give you an example, let's take two scenarios. In both cases, the patient comes in, they start with a pain severity of 9, they're not working, they're sedentary, they're afraid to leave their house alone, and you say, okay, I can tell you're miserable, your back pain is terrible, I'm going to initiate a trial of opiate therapy. And you could say, okay, I want you to come back, we're going to see how you're doing later. So let's just say 4 weeks later, they both come in, they both have a pain severity of 8. But one's managed to get back to work part-time. He's joined a gardening group and he visits his grandkids on the weekend, right? The other one is still not working, sedentary, and his depression's getting worse as he sits at home, right? If you just monitored pain severity, those patients look identical, but I would argue the first one's a successful trial, the second one is a disaster, and you need to stop. You need to stop one, but the other is just fine. And I just emphasize, pain's not so bad necessarily if you feel like it's getting you somewhere, if it's taking you somewhere happy, right? Like people who exercise a ton do it despite the fact that they're causing themselves a ton of pain, right? They may not be like, they're not necessarily feeling good. He's clearly in pain right there, but I don't think it's bothering him particularly much. Whereas, if you're experiencing pain and it's stopping you from living your life, that's going to go bad places eventually. So how do you do this? You got to really focus. You got to start by setting functional goals. You want to, and these should be patient-centered. You can make suggestions. I will say, most clinicians struggle with this. It seems like something simple to do, but it's actually pretty hard to come up with concrete goals. So the first thing you need to do is work with your patient, try to come up with something concrete that will make their lives better, that they care about. You then need to come up with reasonable intermediate steps, because generally people don't make up goals that are reasonable, right? Like they will say, okay, I want to go from laying on the couch all day to, I don't know, running a marathon, right? And you're just like, well, that's just not going to happen, right? So what are all the individual steps that would take you from lying on the couch to running a marathon? And you've got to line those out so they have something to work for. And then you got to document and monitor whether people are getting there, right? And there's, all sorts of different examples depending on how bad the patient is and what matters to them. But the key is you're going to monitor. Ideally, you ask them to keep a diary about whether or not they're making progress towards their goals, what they've done to get towards their goals, what things they might have run into trouble with in trying to get to their goals. And then you want to assess for mood, pain severity, drug use, and sleep as secondary indicators of progress. And ideally, you monitor them as much as possible, but this is also something you don't have to do this. Their loved one could do this. They could do it themselves, right? Like this doesn't necessarily have to be something the clinician does, but we need to clinically set this up so that, because people don't do it naturally. Let's just say that. So just as an example, let's just say you talk to somebody, the thing that they really want to be able to do, it's bugging them that their pain is stopping them from doing, is they really want to go to their grandson's soccer games. But in order to do that, they're going to have to walk across this bumpy, horrible field and then stand for an hour and a half because that's just where it is. So you say, all right, well, that sounds like a hard thing to do from where you're starting, so what are we going to do? So to start, I just want you to take 10-minute walks 3 times a day so that you get better and stronger you're walking. I want you, for every TV show you want, I want you to stand up for part of it, right? Like maybe it's just 3 minutes the first one, and then we'll go up to 5, then we'll go up to 15 minutes. But I want you on your feet more, and then maybe let's do something kind of aimed toward your goal. So maybe your son could help you walk to the soccer practice, and you could stand there for 10 minutes. So your son's soccer game, right? And then what you do is you write those all down. This is what you're going to do. This is our plan. And then you're going to ask them to track progress. You're going to evaluate that progress in the visits, and you're going to use that to guide what you do in order to get the patient better. And I point out that the discussion that goes with this, right, when they come back in and they say, I was too tired to go, I was too tired to go walking. I couldn't do it, blah, blah, blah. Then you say, well, why were you too tired? Well, maybe they have sleep apnea and their sleep's been lousy and you need to send them for a sleep specialist. Things come out of this that you wouldn't expect, that don't come out when you talk to people about their pain and pain alone. And so if you want an example, so you don't want to make these tools yourself, this link has a nice example of a functional goal tracker with instructions and how to use it and the like, if you want to play with that clinically. But I think this is what gets done in multidisciplinary pain clinics. This is what pain specialists do. This is why pain specialists almost always insist on having, a psychologist and a social worker on their team, because without this, you're running blind and you're most likely making things worse. And just to give you another couple of examples, right?